Hello everyone, this is Dr. Sangeeta Chaudhary once again and I welcome everybody to my class. In my today's class, I am going to discuss about hyperthyroidism, which is a very important as well as a very interesting topic. Many of our patients, they do suffer from hyperthyroidism. So we really need to know how do we diagnose such cases, how do we treat, when to treat, whether they require really treatment or not, and if they require, how long they need to be treated. So we are going to discuss all these questions and answers in today's class. So let's begin. Before we talk about hyperthyroidism, we need to know what is thyrotoxicosis. Now, what is thyrotoxicosis? Thyrotoxicosis, it is a state of high thyroid hormone in tissues. Okay. Now, what is the difference between thyrotoxicosis and hyperthyroidism? Hyperthyroidism is a form of thyrotoxicosis where there is increase in thyroid hormone because of high synthesis and release of thyroid hormone from the gland, right? So thyrotoxicosis may be due to hyperthyroidism and may be due to other causes also, which may result in increased thyroid hormone in tissues, okay? But hyperthyroidism is due to hyperfunctioning of the thyroid gland, resulting in increased synthesis and release of thyroid hormone from the gland. Now let's talk about the causes of hyperthyroidism. Most common cause of hyperthyroidism is Graves' disease. It is usually seen in young patients and it is due to autoimmune pathology. And Graves' disease has certain typical manifestations which are not seen in other forms or other causes of hyperthyroidism. For example, proptosis or exophthalmos and pretibial myxedema. These are usually seen in cases of Graves' disease only. Other than Graves' disease, other cause of hyperthyroidism can be toxic multinodular goiter. There may be cases of iodine-induced hyperthyroidism. For example, drug-induced like amiodarone-induced hyperthyroidism. Amiodarone contains iodine in it. And then hyperthyroidism due to radiographic contrast media, okay, iodinated contrast media. Then thyroid adenoma can result in hyperthyroidism. Subacute thyroiditis, postpartum thyroiditis, these are other causes of hyperthyroidism which causes hyperthyroidism very transiently. So these are transient causes of hyperthyroidism. In subacute thyroiditis, there will be painful goiter, right? And in cases of postpartum thyroiditis, goiter is usually painless. So they'll have painless goiter. So these are some important causes of hyperthyroidism. Graves' disease, the commonest cause, then toxic multinodular goiter, then iodine-induced hyperthyroidism, thyroid adenoma, subacute thyroiditis, postpartum thyroiditis. There are other causes of hyperthyroidism, less common causes of hyperthyroidism as well. Now coming to the clinical features of hyperthyroidism. Okay, so what are the symptoms with what the patient will present to us? The patient may complain of heat intolerance, right? A very important clinical feature of hyperthyroidism. Whereas we have discussed in hypothyroidism, they'll have cold intolerance. They may complain of weight loss, weakness, palpitations, anxiety, and in females, they may have oligomenorrhea. Right? So there may be various manifestations of hyperthyroidism. These are some common clinical features or common symptoms of hyperthyroidism. In elderly, they may present with what is known as apathetic hyperthyroidism. Now, what is apathetic hyperthyroidism? It is an atypical variety of hyperthyroidism where patient will present with atypical features. This type of hyperthyroidism, they usually have insidious onset, means slow onset, and the patient may present with weakness, weight loss, sometimes they may have even depression and cognitive decline. So this is seen in elderly and we really need to be suspicious. We should have a suspicious mind to diagnose these cases of apathetic hyperthyroidism because they will present with vague symptoms, okay, non-specific symptoms. Now, on physical examination of a patient of hyperthyroidism, what are the features we may get? Okay, the patient may have fine tremor in hands. Okay, we should look for tremor in hands. Hands, usually they'll be moist because of increased sweating. Brisk, deep tendon reflexes. So when you examine for tendon reflexes, deep tendon reflexes, they'll have a brisk response. The patient may have proximal muscle weakness. Okay, there may be features of Graves' ophthalmopathy. I'll discuss about Graves' ophthalmopathy separately in my other class. Okay, cardiac features, they may have tachycardia, they may present with atrial fibrillation, they may present with heart failure or exacerbation of heart failure, or they may have exacerbation of coronary artery disease as well because of hyperthyroidism. Now, there is something known as thyroid acropathy. Okay, what is thyroid acropathy? Thyroid acropathy is usually seen in cases of Graves' disease. Okay, the patient presents with digital clubbing. Okay, they'll have digital clubbing both in hands and feet. There'll be, okay, periosteal new bone formation as well. Okay, new bone formation, soft tissue swelling in the digits. Okay, so this is known as thyroid acropathy, right? Digital clubbing both in hands and feet. There will be periosteal new bone formation and soft tissue swelling in the digits, right? And there is something known as thyroid dermopathy as well. What is thyroid dermopathy? It is also known as pretibial myxedema. Okay, here there will be a typical manifestation in the skin. The skin will be, firm, and it will be waxy. It will be like the appearance will be like of orange peel, right? Orange peel, and usually it is seen over the shins. That is why the name given as pretibial myxedema, okay, which is also known as thyroid dermopathy, usually seen with Graves' disease, but sometimes it is seen in cases of, Hashimoto's thyroiditis. So skin will be firm, waxy, it will be like orange peel, and it is usually seen over the shin, okay, in the pretibial region. Now, other features, like there will be features specific for Graves' disease, like as we have already discussed, proptosis, then pretibial myxedema. If there is goiter, it may be painful or painless goiter. Painful will be in cases of subacute thyroiditis, painless goiter in cases of postpartum thyroiditis, right? And there will be features of thyroid storm. Okay, I'll discuss about thyroid storm in my separate class. So these are some typical manifestations or clinical signs which we will find in cases of hyperthyroidism. Fine tremor, brisk tendon reflexes, deep tendon reflexes, proximal muscle weakness, features of Graves' ophthalmopathy, cardiac manifestations like tachycardia, atrial fibrillation, heart failure, exacerbation of CAD, then thyroid acropathy, thyroid dermopathy, Graves' disease specific features, goiter, painful or maybe painless, and thyroid storm features. Now coming to diagnostic testings, okay, how do we diagnose a case of hyperthyroidism? Along with the clinical manifestations, we will need support of the laboratory parameters to diagnose case of hyperthyroidism. So typically in hyperthyroidism, what will be the feature in thyroid function test? Okay, TSH will be suppressed, free T4 or free T3 will be high. So this is the typical features of hyperthyroidism. If the TSH is normal, okay, normal TSH virtually rules out cases of hyperthyroidism. If the TSH is suppressed but free T3 and free T4 is normal, then it will be considered as subclinical hyperthyroidism. I'll discuss about this entity in a separate class. TSH may also be suppressed in severe non-thyroidal illness, right? So not only in primary hyperthyroidism and subclinical hyperthyroidism, TSH will be suppressed. It may be suppressed in cases of non-thyroidal illness as well. Next test, what we can do is radioactive iodine uptake, RAIU. Okay, what we're going to see if we are doing this test, we are going to see in conditions where the thyroid gland will have an elevated or high uptake of radioactive iodine, and in certain situations there will be low uptake of radioactive iodine. High uptake will be seen in cases of Graves' disease and toxic nodules, okay, toxic multinodular goiter. Low uptake will be seen in cases of postpartum thyroiditis, iodine-induced hyperthyroidism, and factitious hyperthyroidism. Now, what is factitious hyperthyroidism? In factitious hyperthyroidism, there will be, there will be intentional intake of excessive thyroid hormone, right? Intentional intake of excessive thyroid hormone. This is usually seen in patients with attention-seeking behavior. Okay, they'll ingest too much of thyroid hormone to fake the symptoms of, or to create the symptoms of hyperthyroidism. So in such cases, the radioactive iodine uptake will be low. So radioactive iodine uptake is usually done to differentiate between these causes, right? Causes with high uptake and causes with low uptake. Coming to the last portion of this particular lecture, differential diagnosis of hyperthyroidism. Differential diagnosis of hyperthyroidism in presence of goiter. So, depending on the variety or the clinical feature of goiter, we can diagnose, or we can at least have some idea that what type of hyperthyroidism or what cause of hyperthyroidism it may be. So, diffuse non-tender goiter is seen in cases of Graves' disease or painless thyroiditis. Then multiple thyroid nodules seen in cases of toxic multinodular goiter. Single thyroid nodule seen in cases of thyroid adenoma. Tender painful goiter seen in cases of subacute thyroiditis. Normal thyroid gland, okay, patient have hyperthyroidism but the thyroid gland is normal in palpation. This is seen in cases of like Graves' disease, painless thyroiditis, or factitious hyperthyroidism. So these are some causes of hyperthyroidism which we can differentiate depending on the appearance of the thyroid gland, okay, and whether it is tender or not, right? So this is all about today's lecture. In my upcoming lecture, I will discuss about the treatment of cases of hyperthyroidism. Thank you so much for attending this class.